Like, we still had to monitor and make sure, because you're not an adult, right? So we had to make sure everything was good. So you really get to know those kids, but like, smart kids, they really learn a lot, and they understand, and they know their body. But those pumps make their life so much easier. Hard part is getting that carb count, but we'll get to that. But insulin is required for type 1 diabetic. It can be prescribed for type 2, particularly during times of stress. Remember that cortisol, we're gonna have extra glucose floating around, so we might need to give them or adjust insulin dosages during the times of stress, or as disease progresses, or if they're unable to manage, they've got some other illnesses and or just geriatric considerations, they might require some more insulin. The insulin's we use genetically engineered. We don't use like, there's a really cool video out there, I won't take the time for it, but on how insulin was invented, if you're ever curious or interested. But it goes on to the whole bovine insulin and where they got insulin originally from and getting injected with animal stuff into people, all that fun stuff. But we genetically engineer it in the laboratory, thankfully. It is very expensive lately. But we have different types. So you all know this, you've been introduced to it, right? Perhaps, you're probably looking it up for your sim chart. We have rapid acting, short acting, intermediate, and long acting. What does that mean? What do I mean by that? Well, how fast it works, yeah. Onset, peak, and duration. So when does it kick in? Where is it working at its best? And when does it trickle off? Okay. There's a chart in your book, but I kind of took it and then I made this chart out of it, just to kind of let your eyes wrap around it a little bit more. So we've got rapid, short, intermediate, and long. We've got the different examples on here. And then we've got our onset, peak, and duration. Why are those times important to us as nurses? Why do you think? Why do we want to know, particularly about the peak? Say again? To know when their sugar is going to be the lowest. I need to be monitoring for hypoglycemia during that time, right? What about onset? What does that tell us? So it's particularly with rapid, the onset starts working in 15 minutes, like 10 to 20, 15, I picked somewhere in the middle. Your book might say like 30 minutes, but rapid's a little bit faster than that. It's more like 5 to 10 minutes. Why is that important? You guys given Lispro before or Humalog? Yeah, probably clinical. That's a really popular one. Rapid acting. When are you giving it?
Right before meals.
Right before meals. Right? Rapid onset. So we don't want to give it too long before. We don't want to give you the Lispro or the Humalog, and then they don't eat anything for like 30 minutes to an hour. They could do what, Celeste? Drop their sugar if they don't eat. So if it's something that's going to work pretty quickly, you're going to take it right before you're eating, right? So that while you're ingesting food and you're raising your blood sugar, you got your insulin working on it, right? And you might bottom out at that peak, so we better have had a meal before that 1 hour, right? So we've got Humalog, Novolog. Notice the pattern, I've underlined it. Logs. Logs roll fast down a hill. Fast, rapid. Duration is 3 hours. Sorry, I saw that click. Short is your regular insulin. So it takes a little bit longer. This is what we used to use more before we had Lispro and Aspartin and the glucine. We would routinely give regular insulin. Don't see that as often now because we like the rapid one. Because people don't want to take their insulin and then wait a little bit before they start eating. Usually they'll eat right away, but then the insulin kicks in after they finish their meal, right? You get your onset 30 minutes later. You've already spiked your blood sugar, now your insulin's kicking in. It really kind of created a little bit of chaos in that flow of their insulin, right? And their blood sugars. So we could do that. Regular insulin you can purchase at Walmart over the counter. Did you know that? Or maybe you could like a year or two ago. Yeah, but you can't buy any prescription for the other stuff, so that's helpful for people who are traveling and they don't have their insulin, but then they have to adjust what they're doing with it and get an order from their doctor to know what they're doing. It's just a fun fact for you. But anything with an R in the end, so you've got Humulin or Novolin R, those are your short-acting insulins. So think regular with short. Okay. Peak is about 2 hours. Stays in the body a little bit longer than that rapid-acting, right? So intermediate, we have NPH. You guys know this one too. Remember lab, NP1, or checkoff. So intermediate, it, stays around a little longer. Takes a little while for the onset. Peaks about 8 hours. That's important to know because when do people take NPH? Do you know? Do you have anybody or have you had anybody you weren't there because you don't do, or our evening clinical folks. Have you given any NPH to any of your patients in the hospital in the evening shift? I've already told you when you did it. It was one of our evening longer acting insulins to kind of sustain that blood sugar while they're sleeping. But depends on what time you take it because it would peak while they're sleeping, right? So that's why we like these new longer acting ones that kind of carry them over a little bit longer. Doesn't really have a peak. It's just kind of an onset and it's just stays steady, right? I'll show you a graph in a minute. I think, the next slide. So we tend to see those more than we see NPH now. That's why you're all like, oh, I don't think I did it. Not many of you have had an evening clinical. So we taught you how to mix it in NP1 and then you don't use it, right? So my adult nursing was like 20 years ago. We used it then. And I think, oh gosh, am I that old? Some of this stuff wasn't really around, or maybe we just didn't use it where we were. But so we gave NPH a lot. But I haven't seen it in like 20 years, except like maybe it was 2021. It was one of our ketoacidosis kids in the PICU was traveling, visiting family from Mexico, and that's why I said, maybe you're traveling, you don't have your insulin, right? They had to go buy NPH and regular for him at Walmart, because he didn't bring his insulin with him, teenager, totally non-compliant. Comes to visit family in the US, and then ends up in ketoacidosis while riding the bus, city bus. Got real sick, ended up in the hospital. So, I know I'm telling this story, but it's okay, and here, we're in a learning environment. It's not HIPAA. But, we hardly ever see that. That's important to know. So your short and intermediate isn't as common, but it's still out there, right? So we still have to make sure people are educated about it, or if you see it in the hospital, because that's what that patient is using. And that's what they're going to continue to use while they're in the acute care setting. So it's important to know about it. And then your long-acting, so this is the glargine and the detamere. You guys familiar with those? Any evening shifters give those? So like I said, it's got a 2-hour onset and it carries them throughout the night. So it's easier to remember these if you know their brand name, because if you see Lantus and Levemir and think long-acting, those are your L's, right? Logs roll down the hill fast. The Levemir and the Lantus are the long-acting. Does that help? Maybe? Graphs are good too if you're visual. Just kind of shows you just a little bit about your time, your peak, and your onset, a little bit about duration. So these numbers might not exactly fit the one in your book, but it's around about pretty close. It's just talking about onset and peak durations at the bottom. You got your rapid, you got your short, you got your intermediate, and that long acting. There is a good chart in the book that'll show you that long acting, just kind of how it really doesn't have a peak. Okay, so what's our plan when it comes to insulin? Think of it as in like basal and bolus. So that's where you're long acting and short acting. Why do we have both? Why are we using one and not the other? Usually we use both, right? We use a rapid acting and a long acting for most people. So we'll be giving multiple injections, or we'll have a pump, especially if you require insulin because your body doesn't make any. It'd be nice to have a pump because you need a basal rate to kind of keep you steady, have that constant flow of insulin throughout your day and night. So if you're on an insulin pump, you're going to have continuous glucose monitoring too. So they'll have a sub-Q port, kind of like a catheter that's injecting the insulin, and they also have a subcutaneous glucose monitor. So the bolus is that rapid, that short-acting insulin that helps them around meal times, right? Taken before meals. helps with that food, the glucose spike that you get with your meals. And then your basal is your intermediate and your long-acting, that kind of sustains you. So routinely for our type 1 diabetics that require insulin, they don't go right to the pump right away. They're doing the long-acting and the meal injections and the frequent monitoring. And they do that to kind of help them learn how to manage their diabetes before they go to the pump. Because they can have mistakes with their pump until they truly understand what the pump's doing. And then the pump, again, is for somebody who needs that insulin because they don't make any, so you're not going to see a pump necessarily on a type 2 diabetic. I won't say it's completely impossible, but for your type 2 diabetic, the insulin medication isn't their go-to source for treatment, right? This is kind of a later resort. So they're going to do injections more likely, or they might do some kind of long-acting, but we'll talk about it, we're going to get there, but we're going to go with oral medications first, and we come to insulin later if we need to. So bolus and basal, with the goal of keeping that level close to normal, acting kind of like how the body would act if they produced insulin, so that's why the pump is so nice. It mimics it pretty similarly. And a lot of our pumps are getting more and more advanced, and so it's communicating with their glucose monitor, so they don't have to go in and tell it when to do a bolus. The pump just does it. It can sense that rise in blood sugar as they're eating, and the pump gives them their bolus. They're not even thinking about it. Most of the pumps I've worked with kids, they gotta plug in the carbs and the pump. It's like a little cell phone. They gotta plug it in. Some of them can do it from their cell phone, and it communicates to a smaller pump, right? So they can plug it into their app, put in the carbs, it does its own little algorithm and determines what their bolus is, and it just communicates and goes. Like a walking robot. Alright. So mealtime, the bolus insulin, usually rapid or short acting, mimics natural insulin in response to meals. We got Lispro, aspartame, glucine, the Humalog, the logs that roll, right? So just another slide to kind of gather for your studying versus that chart. So you need to look at it a little bit closer. Regular talks about our onset and about when you would inject, so 30 to 45 minutes before meal. Here's a slide for your intermediate, your NPH. Novolog, your Humulin. So we can mix this. Remember, that's what you all learned in NP1. We taught you with regular, but you can mix it with short and rapid acting insulins, but we don't usually. They have more, like those insulin pens that can have mixing in it too. Longer acting insulin are available in pens, and some just go ahead and do their long acting and their short acting separate. We never give any intermediate or long acting IV. There's actually only one type of insulin that's ever given IV. Anybody know? Which type of insulin is given IV? Not heard of it? Regular insulin. So if somebody's going to need a continuous IV drip of insulin, again, that's critical care, it's going to be regular insulin. That's the only type that can be given IV. All the rest are sub-Q. There's your Lantus on a little sneak peek at one of the pens looks like. I got a video coming up on how to use a pen. This is used with mealtime insulin, so in combination with it, right? To manage glucose levels in between meals and overnight. So it's that basal. So that fast acting handles those high spikes of sugar, while your long acting just kind of keeps you at that steady basal rate in between, right? Release steadily, continuously. That's why we have that longer duration. Once or twice a day. Usually if it's once a day, they usually do like an evening dose, but some people might require an evening and a morning. So yes, this longer we're not going to mix or dilute, so it's just your intermediate, your NPH, that can mix. A little bit about the combination and the mixing. And I liked this picture for you because that's a good way to remember if you forget clear and cloudy, right? If you put them next to each other, it spells out RN. The clear, then the cloudy, right? Okay, and mix the short or rapid. Like we said, this is repetitive a little bit, but it kind of organizes you for your studying. short or rapid with intermediate. So the point of doing this is because it might be time for them to have their long acting and they're also having a meal. So we need to cover that quick acting and give them their longer acting without having to poke them twice. Oh yeah, and then this bottom says consider visual, manual, and cognitive skills. And this is, we had to help you with your cognitive skills for your checkoff and NP1 and learning. And that's difficult for you. Can you imagine somebody who really isn't understanding medically how this works? Why do I need to do it this way? Why are you making me do that? And all that stuff. So we have to make sure that we can teach them how to do this, or we might decide to do a different method for our patients. Storage is important because it needs to be refrigerated, right? And we live in a hot climate, so we don't want, it's gonna be not as effective. So if somebody left it in their car, and it was 1,000 degrees in August in Oklahoma, that insulin is not gonna work for them. They're gonna be injecting and thinking they're good and covered, and their sugars are gonna be out of whack, and they're gonna wonder why. Same with the cold side, right? Doesn't work that well. Vials and pens may be left at room temperature for 4 weeks. So those pens, you know what I'm talking about in the picture, they're usually good for 28 days, and they don't need to be refrigerated. Some of them might though. They have little mini refrigerators for them, and some people might just want them colder. Doesn't make it inactive. It just doesn't require refrigeration. Some of them. Let's see. Refrigerate any unopened insulin. Avoid exposing it to direct sunlight. So don't leave it on the dashboard in the car. The heat and the sun is going to ruin it. Thermos or cooler. Now they got all these neat little things online. This is a little ice pack. They can swap it out. Put a little insulin in it. Tuck it in a little sleeve. Stick it in their purse or the bag. So it says storage of pre-filled syringes upright. So that's if you have a needle attached to it, which you really shouldn't anyway, but it's because they can leak. So you don't want the needle up so that the liquid stays down and doesn't leak out the needle if you put it upside down. Okay, let's see. Insulin sites, you guys know that, but here's a reminder for you. So your subcutaneous areas, usually the back of the arm is the preferred site, or for self-injections, abdomen's a pretty good area, the upper buttocks and thighs. We'll talk about like the rotation in a little bit and the complications that come with that, but you know you need to rotate those sites. We're not going to be poking the same spot over and over again. So the user is the only person who recaps that needle, right? After injecting it, just safety. No alcohol swab. So we add, this is how what we teach them for self-injections, because that's going to break down skin over time too. So just general soap and water to clean their sites, you know, for self-care. But in the hospital, we're probably going to use alcohol because we have a lot more nosocomial infections. So, and it's temporary. Usually most hospital stays are temporary. So we'll use alcohol for the most part in hospitals, but we'll teach our patients at home, they can do soap and water to clean and do their injections. Let's see. Insulin pens are pretty convenient. It's a dial and go. Actually, really attach a needle, dial your dose and go. It can be pretty discreet because you're not having to draw up in the middle of a restaurant, get everything out, open your cooler. I have a friend who's diabetic, and it is pretty convenient for her. She usually still doesn't want to do the pen in the restaurant. She'll do it in the car before she goes in. And it's like, oh, you got 15 minutes. Let's hope they give you your food. So anyways, I don't know that she's the best at managing diabetes. But the pens are super nice and convenient. And they're super tiny, like those needles. Like I wonder, like how you wouldn't even feel it. They're so tiny. And they're really good for people with poor vision. Dialing up those insulin pens because they can hear those clicks, click, 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 and they can kind of count if they know how their numbers go on their pen. Really hard for somebody to draw up insulin and see on that teeny tiny little insulin syringe, right? Where is that dose? Okay. So how do you use an insulin pen?
Hello, my name is Mara, and I'm a certified diabetes educator here at Boston Medical Center. Today, I will be teaching you how to prepare and inject insulin. Insulin is a medication that is prescribed for people with diabetes. You may be prescribed insulin in a vial, and you will use a syringe to inject it. It also may be prescribed as a pen, and you will use a pen needle to inject it. Instructions for injecting insulin with a pen and pen needle. Always start by washing your hands. If you take 2 insulins, check the pen label to make sure it's the insulin you intend to inject. It's a good idea to write the date on the pen of when you first opened it, as it is only good for 28 days. Take the cap off of the pen and wipe the tip with alcohol. Choose 1 pen needle. Tear the paper off and keep the needle in its safety cap. Screw the pen needle onto the pen until it stops turning. Take the white safety cap off and remove the colored needle cover. Perform an air shot by dialing to 2. Hold the pen up and away from you, push the injection button, and look for a drop of insulin on the needle tip. If you don't see a droplet, repeat this step. Your needle may be bent if no insulin comes out, and you should replace it with a new pen needle. Repeat this step until you see the droplet form. Turn the dial to the correct dose of insulin. For this example, we will use 10 units. Wipe the skin with an alcohol pad. Dry off any excess alcohol on your skin before injecting. Do not inject through clothing. Pinch a fold of your skin between your thumb and finger. With your other hand, hold the pen at a 90-degree angle to the skin and insert the pen with 1 quick motion. It helps to hold the pen like you're giving a thumbs up and push the pen injection button with your thumb. Push the injection button at a moderate and steady pace until the insulin is fully injected. Keep the needle in your skin for a count of 10. Then you can pull it out of your body. Remove the needle from the pen by replacing the large white cover and unscrew it. Dispose of your used pen needle in a safe sharps container. Never leave the needle in your pen. Doing so can result in leakage or air bubbles. For more information on how to properly rotate your injection sites for both syringe and pen needle delivery, watch the animated insulin video on the website bmc.org/diabetes.
So it's a patient education video, clearly, but it's good for you to see those kind of things. Look up patient education videos. It helps you explain things to you, but it teaches you how to teach your patients as well. So it's a good video to show you if you've never seen anybody use one. Pretty simple, convenient, just gotta attach the little needle to it. There you go. And I've talked about insulin pumps because they just get me so excited about insulin and diabetes because these are so nice and convenient. So it's a continuous subcutaneous infusion of rapid-acting insulin. So there's a device that they, when they do site care on their skin, they'll place the device on. It's got a little button that clicks and it inserts a little teeny tiny little catheter. So kind of like an IV, but like for sub-Q, little IV catheter, super tiny. And so it's inserted to the subcutaneous tissue. So it's going to be a small amount that's absorbed through subcutaneous into the capillary bed. Is that some pumps are tubing free, meaning it's a device that has the insulin all in itself. So it looks like one of those continuous glucose monitors, but a little bit bigger, about this size, on their arm, maybe a little bit shorter. So they might have a CGM on one side, and they might have a pump. I think the girl in the video, I don't know if you got a chance to see it, I think she had one of those too. So she had one of the pumps that doesn't have tubing. It's got the insulin in it, and it's connected subcutaneously to their arm, or they can put it in their abdomen, and there's no device with tubing. So this is what I'm talking about, this tubing here. So it kind of looks like this, but a little bit bigger. So it's pre-filled with their insulin, and it's got the catheter insertion and everything good to go, and it communicates with a CGM, like I was saying before, where it can, some of them can sense what their blood sugar is and give a bolus. Some of them you have to enter the carbs, and it goes through the algorithm and communicates a bolus that way. So most sets need to be changed. So this piece right here would need to be changed every 2 to 3 days. It's programmed for basal and a bolus. course, that's based on carbohydrate intake. So there's a formula, and it depends on what endocrinologist your patient might have and how they're going to order their insulin for type 1 diabetics. So based on their carbohydrates and some formula that it goes through, it determines what their bolus would be. But again, that's like pre-programmed into some of the pumps, and all they have to do is put that carbohydrate. So there's a factor that goes along with it that's prescribed. I was going to show you the formula, but again, it's different depending on facilities and endocrinologists and what they want to use for that patient. And then check glucose 4 to 8 times a day or continuous monitoring. So the continuous is nice because they can look at it. And it really helps people to see, because people react differently to different sugars. So some people have a higher spike on our type 2 diabetics, have a higher spike of insulin with certain carbohydrates, and others have a nice steady low response. So, but the pump is going to keep and see how they're reacting to their foods and how their insulin is working for them. So obviously there's a major advantage. It keeps it in a tighter range. It can interact quicker with insulin, acting more like what their body would if they produced their own insulin. Obviously more flexibility. They can run and play and do sports with the pump. But there are some concerns. So there can be infection at that insertion site. Sometimes if the pump's not working right and it's not infusing properly, then we can have our blood sugars go high, or you can have false lows if that catheter is getting old. So we might be treating a inaccurate blood glucose because of the CGM, not reading right, or the pump is not pumping right. So there's double checks that they can do, or if they feel differently. This is when education is really good, or if they've been managing their diabetes for a while and they feel their symptoms aren't really matching the numbers. Kind of like when you walk in the room, you see the vital signs, you're like, patient's pink, why does it say they're at 70, right? Same kind of thing. I'm feeling okay, why does it tell me my blood sugar is 40? You know, maybe I need to do something else. How do you verify if your pump is malfunctioning or not? Say again?
Double check it.
Double check how? Finger stick. Just go to the old dinosaur, get the blood glucose check. Those can fail too, right? Is it calibrated? So we really have to, if they're super concerned, they can go to their provider and have them double check. So always go to the symptoms, because our lab results aren't always the number one thing, right? How are you feeling? Does this fit the overall picture of what's going on? So other problems with insulin therapy, so glucose lowering agents and insulin. So if we're taking oral diabetics and then we need to supplement with some insulin, that can cause problems. It's hard to really detect what's the issue when their glucose isn't controlled very well, right? So we don't want to go to insulin. Insulin's kind of like our last resort when you're talking about type 2 diabetics. Especially if you're talking about somebody who's insulin sensitive. So we really want to make sure that we're addressing that insulin sensitivity in their diet and getting control of those spikes with their blood sugar, so that we're not creating more insulin sensitivity. But yet if they're at a point where they're requiring insulin because their sugars are so high, we go and we throw more insulin on them, right? So they're getting more exposure to insulin when they're already becoming sensitive to that, or not sensitive, resistant, resistant to the insulin. So the more insulin we throw at them, the more exposure to that insulin, the more the resistance worsens. So it's really not ideal. It's kind of our last resort. We don't want to do insulin unless we have to. Right? We want to get blood sugar under control, but then we want to back off of it so that we can address that sensitivity. So that's our type 2. Does that make sense? Right. So when we're doing combinations of things, it gets really difficult to determine what's going on with their blood sugar. Is it because of their diet? Is it because of their insulin? Is it because of oral medications? So, this takes up, like in the video, it takes up their whole life. It's on their minds all the time. Like, can I eat this? I need to check my blood sugar, right? It's like, you don't want to pause life every time, like, just to check your sugar. So there's cognitive, psychomotor, and affective issues that go along with diabetic management and with insulin and understanding it and how it's so important. We've got so many people mismanaging their insulin, intentionally, unintentionally, and it requires a lot of education. So that's where follow-up, self-management behaviors, side effects of therapy can be an issue. It's a whole team that can come together, so the nurse alone isn't necessarily the person who's helping them. They have an endocrinologist, a diabetic educator, pharmacy, all kinds of people that can help them with managing their diabetes. So obviously hypoglycemia, right? So if you get too much insulin, what happens? Blood sugar drops, right? There can be allergic reactions. Can you imagine if you're diabetic and you're allergic to insulin? Extremely rare, but it exists. Or even just like frequent exposure to latex type materials. So we're gonna make sure that because it's a chronic illness, we don't want them to be using latex products in all their diabetic supplies. And then this lipodystrophy, the changes in that subcutaneous, this is the issue with the reason why we rotate sites for your insulin injections. So we can create, it's like a thickening of that subcutaneous, it's like scar tissue in the subcu, and it can cause problems with absorption of that insulin. So if your patient's not rotating sites, their sugars might be kind of out of whack, and they're wondering, well, how can I get control of this? A1C's showing up high, they've been kind of using the same spot over and over again. Well, it's not going to absorb as well, right? So we want to make sure we're rotating those sites. There's the Simoji effect. So this is the overnight, this is an effect, and then there's the dawn phenomenon. They kind of converse each other. This is the one at night when kind of in the hours of sleep. So you can think, Simoji effect is, or sleep, S for sleep, sorry. So high doses of insulin can cause this. So especially if they're getting like a nighttime evening dose, they can drop their sugar throughout the night, usually around like 2, 3 a.m., 4 a.m.-ish. So if their doses are too high, we can have that bottom out effect in the middle of the night. This happens a lot with our newly diagnosed type 1 diabetics. So their body's adjusting to that insulin that we're giving them, and then they tend to bottom out. So even if they've been doing well, they're starting to eat in the hospital, they're getting ready to go home, this is when I'm checking their blood sugar at 2 a.m., even though the orders say we don't have to check it until morning. I'm like, I don't know, let's check it at 2 a.m. and see. And sometimes it's a little lower than we like. All right, so we're assessing for headache, night sweats, nightmares. If their body, if they're starting to feel ill, it can kind of bleed into their dreams. Treatment, they could have a bedtime snack, so we don't want to adjust the insulin dose because maybe it's a one-off thing, they had just a funny night, but they've been doing well on that dose for a while. We could probably throw in a bedtime snack and then maybe reconsider adjusting their insulin dose, or maybe do both, the snack and the adjustment. And the dawn phenomenon, this is when their body is preparing for those waking hours, so it knows you're about to wake up, you're getting to the end of that sleep cycle, and so your liver's gonna kick in and start throwing some sugar around, getting ready for you to get up and work on the farm, right? Use all that glucose. So it's something your body biologically does. So it's due to those counter-regulatory hormones. It's sensing that drop of the sugar in those early morning hours, and so it's gonna release some of that glycogen to glucose and send it back in the bloodstream. Growth hormone would do that, so that's more severe in adolescents and young adult. Peak time for growth hormone is at that time, so it can create a bigger dawn effect. So again, something else with our type 1 diabetics. So this is the opposite, so maybe we need to look at adjusting that nighttime dose, so we still have a little bit of insulin, laying that long-acting insulin that's still in their system by the time they're waking up and they get that peak in their blood sugar. Got it? So this is new too, this inhaled insulin, Afrezza. So this is with your rapid acting, right? Usually prescribed, I've not heard of it with the patients I've worked with, but it's out there for people who probably really can't do the needle thing. But it's a rapid acting insulin. It's at the beginning of each meal, right? So they have their basal, but this is your bolus, right? used in combination with long-acting, right? Because they're still requiring that insulin, so we need that basal rate. It's tough to make sure that they get that full dose, right? Because you know about even your inhaled medications, your multi-dose inhalers, or your inhaled corticosteroids. You know, if they're not taking a nice deep breath, we're not sure that they're getting the full dose, so it can have some hypoglycemia or hyperglycemia, it can cause a cough, a little irritation, it goes into your lungs. So, and your lungs are very vascular, so that's where it gets into the bloodstream that way. So it's not really ideal, but it might be good for certain patients. And if they're smokers, you've got that tar in your lungs, so that can kind of decrease the absorption of the medication and make it not work as well. COPD, asthma, any kind of lung issues, we've got some damage maybe at the capillary bed in their lungs, so it's probably not going to absorb too well. Right. Oral medications. So they work in different ways. They can deal with the insulin resistance piece and help make our body more sensitive to that insulin, make that insulin that they do produce work better. It can work by decreasing insulin production, right? So it can kind of have that pancreas, work on the pancreas there, and then the liver with the it can decrease the liver's production of glucose. I think that's in there wrong, decrease insulin production. We'll talk about it as we go through, it's gonna make more sense. So this slide could be confusing. So it can be used in combination. So depending on, you know, they watch how their disease progress is working, and they can determine based on some of their diagnostic tests and whether this is a beta cell issue, and then so they can work, if their beta cells are damaged, they can work on the liver and decrease the production of glucose there, or if their beta cells are okay, they just need to stimulate them to produce more insulin, then they can take medications that work in that manner, or they might need a combination. So it's gonna make more sense when we look at the different drug categories here. So these 519s, this is a really common one, the metformin, you guys have had this, right? With some of your patients in clinical, right? It's that first line treatment. So they're gonna give this metformin to some of our pre-diabetics too. So maybe it's been a few years and they're still pre-diabetic and they haven't really developed diabetes yet. They might start somebody on something like metformin. But it's the first line treatment for type 2, immediate release, extended release, or liquid form. So it reduces that glucose production in the liver, right? So it keeps the glucose from spiking in the blood. And it helps with that insulin sensitivity. So it makes that insulin that they do produce work better, right? So it works on their insulin resistance by making us more sensitive to it. And it helps improve that glucose transport. It can cause some weight loss too. And there's, again, it's used in that pre-diabetes. So this is important here. We got a drug alert on metformin. So there's some times where we don't want to give this. It's contraindicated in renal failures for anybody who has any difficulty with their kidneys. And also it's one that we might want to hold if they're going to have any diagnostics that use contrast dye, because that's stressful in the kidneys as well. And that this medication in combination with that dye can throw them into a renal failure. So it doesn't work well together. Also, alcohol with any of these diabetic medications. Alcohol, does not interact well with any of these medications, and it can cause you to drop your sugar too. So if you're on an oral diabetic medication, you're already getting control of your sugar, and then you have alcohol, it can cause a hypoglycemic episode. So not good. And that's more dangerous to a diabetic than hyperglycemia, a little easier to manage. But hypo, they can go into diabetic coma, go unconscious, so that's not good, that's an emergency. So no alcohol, sulfonylureas also. This one in particular can cause that extreme drop in blood sugar. So what's happening with this class of drugs, we're looking at, it stimulates the beta cells in the pancreas to make more insulin. So it's working there to increase insulin rather than working on the liver to decrease glucose, right? So another way of working on the patient's issue. So these are your Zydes and your rides, right? Your glipizide, your glyburide, and the glimepiride, pyride, the amylyl, I'm used to the brand names. Glucotrol, right? So the ride are Zydes. Right? The rides are Zydes. Sulfonylureas. Yeah, this is the most commonly prescribed. So your metformin is your first line treatment or your pre-diabetic medication, and then, but more commonly they'll have a sulfonylurea. So you've seen these too, right? You guys have given the glucotrol, glipizide, right, in clinical. So the meglinotides, or litanides. So this is another, very similar in that it also stimulates those beta cells in the pancreas. Difference here, this one's taken with the first bite of food, so it's directly acting with that glucose spike at the same time that you're eating. Right? Okay, so we've got the repaglinide and the natglinide, so very similar, like we're saying back here. We got the Zydes and the rides and the glinides. Okay, still kind of doing the same thing, working on those beta cells in the pancreas. So even though they're two different drug groups, this one probably has a little quicker onset, which is why you're taking it with food right away. Okay. You got your alpha glucosidase inhibitors. So these are the starchy ones, starch blockers, slowing down carbohydrate absorption in the small intestine, right? Decreasing that rapid spike of glucose. So kind of leveling things out, slowing things down some. Also taken with the first bite because it's working towards the food that you're actually eating. So yeah, checking your glucose later. This is really initially to see if this treatment's really working. So check a 2-hour postprandial glucose to determine effectiveness. And after a while monitoring it, you'll see that this is a good medication for it. They should be routinely checking their blood sugars. But a lot of times our patients who are on these oral medications are thinking, oh, I'm good, I don't need to check as often. But every now and then they should check back in and kind of see. But initially especially, you want to make sure that medication's working for them. So some examples, acarbose. So if you're thinking starchy carbs, acarbose is a good way to remember that particular type of drug. Okay, so here's a good one, the TZDs, right? Thiazolidine diones. I know. Somebody had fun with that one. All right, so this helps with that sensitivity, right? Insulin sensitizers, helping with that insulin resistance. So it's trying to make that insulin that you do have work better. So I don't have a good way to remember these, but you've got Actos and Avandia. You've heard of those medications. The brand names are a little bit easier to remember than their generics. But these are the itazones, right? Maybe if you remember the diones in the end, the itazones. That might be a way to help you put this group together so you can understand this drug class, what it's doing, and what drugs go with it. It's easier to identify. Oh, this is the one that helps with insulin sensitivity, right? But it does come with a lot of side effects. Edema, CHF, weight gain, fractures, and absorption, right? Electrolytes and things like that. Okay, dipeptidyl peptidase 4, DDP4. I have a picture on the next slide that's going to make this a little bit easier to understand. But this has to do with different hormones, all right? So this is where this gets complicated. But this is important to talk about because you're probably hearing a little bit more about our GLP-1 and the GIP. All right, now I'm gonna go right to it. Well, it might even be in here. No, Januvia, you've heard of Januvia, right? Some of these other medications you're hearing more about. Ozempic is also one, we're gonna get to that in a second, but that's why this slide is a little bit helpful here. We've got these DDP4 inhibitors, these medications that, that are gonna block this enzyme, because what this is doing is inactivating our GLP-1 and our GIP. And what these hormones are doing are helping us. They're stimulating insulin release and stop that glucagon release from the liver. So we have somebody with high glucose, we want these to kind of help us to lower their blood sugar, right? We want to stimulate the release of insulin and stop the liver from producing glucose, right? And so all of that helps to lower blood sugar. So this one just acts, these drugs just act on this DPP4 enzyme to slow that down because we don't want it to inhibit that GLP-1, right? So I know it's all these hormones, this is where it gets tricky, but I think this graph kind of helps you with that. So going back a slide is talking about how this medication is going to inactivate that DDP4, so it will stop trying to stop GLP-1, all right? I know. Just sit with it, digest it. But you've got your gliptins here, allogliptin, sitagliptin, which is Januvia. So maybe on how you study with your little, if you do flashcards are not my thing. I like to kind of put everything down on one big piece of paper and categorize it and put it in a little outline. But if you're a index card kind of person, you can have your drug class and what it's doing and flip it over in the back, and then you remember your drugs that fall into that class. That's one way to study. You know, pharmacology is difficult because that's the piece where you have memorizing which medications go with that drug class. But when you study the drug class and learn how this is acting in the different ways that we can get control of blood sugar, whether it's helping with insulin sensitivity, whether it's stopping the liver from producing glucose, or helping the pancreas secrete insulin. That's how all these different drug classes are working, okay? Does that help maybe? Because it's a lot of drug classes. No. You just gotta sit with it, study, and read through it. And if you're understanding the process and what's happening with glucose metabolism and when it's going wrong, then you'll understand why these medications are working in the way that they are. Okay. Another couple of drug classes here. So the sodium glucose cotransporter 2, SGLT2 inhibitors. So this is talking about kidneys. So these are getting to, they're not used as often, but these are out there. So if the issue with your patient is about reabsorption of the glucose from the kidneys, or if it's part of what's going on with them, they might be on these medications. So it's helping, and this is one that probably is combined with something else, because you do have that issue with insulin. So this alone isn't going to help you to lower glucose, but it's one way to get it out of their body if they're producing, and it's stimulating the kidneys to kind of help, hey, we need you to help us out too to get rid of this glucose. So they're going to activate the kidneys with this medication. So here's the glucagon-like peptide 1 receptor agonist. So stimulating glucagon-like peptide 1 to, which is one of the incretin hormones. So these are those hormones that I was showing you before, that GIS and the GLP-1. Increase insulin synthesis and release. It stops the glucagon secretion from the pancreas, telling that liver to take that stored sugar. It slows gastric emptying. You see it does kind of a lot of things. This is why it's becoming more popular. Delays this gastric emptying. So slows down so that we're not having quick spikes. Stuff that's easily, those simple sugars that spike our sugar quickly, tells the stomach that, oh, hold on a minute, let's take this one bite at a time, right? Slow down that absorption of the glucose. That's that delayed gastric emptying. Increases satiety and reduces food intake. It's probably because of that slowing down of the gut, right? So you're feeling satisfied, which causes weight loss. So people are taking this medication for weight loss when they're not diabetic, right? That's where that Ozempic is coming from. You've heard of Ozempic, right? All right. So there's monotherapy or adjunct therapy for type 2 who don't achieve optimal glucose levels. So again, this is one of those, it's not the first line, but they may come to this because it can work in all these different ways. If something simpler isn't working, we can go to these medications. So So here's a nice long list of it, but primarily just to show you, we got Ozempic on here, Trulicity, some of these other meds you've heard about in the news. Okay, so these are injectable medications, right? Sometimes they're once a week, they're not like an everyday thing. That's another ideal thing for somebody, is they might like how they don't have to do a daily injection. So what other medications are important to understand and know about? We've got some drugs that affect glucose levels by raising or lowering glucose. So do you know beta blockers can mask symptoms of hypoglycemia? So if your patient is on those and they're at risk for hypoglycemia, they may not recognize that they're hypo, so they need to make sure that they're checking their blood sugar despite how they're feeling. Okay. And then the thiazide loop diuretic, so your hydrochlorothiazide, for example. A lot of our diabetic patients also are experiencing hypertension, so they might be on a hydrochlorothiazide, which we gotta watch out for because that is gonna cause an increase in their blood sugar. So they need to be monitoring. Or maybe if we're having trouble keeping those sugars under control, they might wanna change to a different type of medication. But then again, they might switch into this beta blocker to take care of their blood pressure, or maybe they'll look at a calcium channel blocker. Again, that's why it gets so tricky to manage diabetes, because there's so many different factors that go into play, and it's so stressful. It's like, I gotta worry about this, I gotta watch what I'm eating, I gotta get up and exercise, and then yet something else is gonna happen, or I've got this other disease process going on now that's gonna affect my blood sugar, and it's just a vicious cycle. All right, do we need another break? It's like the exact same time last hour. All right, let's take a break, come back at 3.